Well, hello everyone, and welcome to our case conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I am both a CL and addictions psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. As many of you likely already know, this event is one of many in a series that we have of case conferences and educational webinars. And our next one is actually going to be Jennifer Knight's Dylan Fisher Research Award lecture about social disparities in cancer. So that'll be a really good one. I would not miss that one coming up. But today's particular 30 to 45-minute case conference will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end with a Q&A session. So if you have questions, please put them in the Q&A option. You can feel free to use the chat for comments, but we will only be answering questions inputted into the Q&A. Our trainee presenter today is Dr. Omar Munoz Abraham. He is a Consultation Liaison Psychiatry Fellow at Harvard Medical School, Brigham and Women's Hospital, Dana-Farber Cancer Institute. And our CL faculty discussant is Dr. Donna Greenberg, who is an associate professor of psychiatry at Harvard Medical School, Massachusetts General Hospital Center for Psychiatric Oncology and Behavioral Sciences. And I won't make you wait any longer. I will hand it over to Dr. Omar Munoz Abraham for his presentation.
Thank you, Dr. Fipps. Thank you for the warm introduction. I want to share my screen. And as you know, today we're going to talk about antidepressant and tamoxifen use in breast cancer. And I'm going to present a very interesting case, but at the same time, a very common case that we encounter in our clinical practice. So I'm just going to jump right into our case. So we present a 30-year-old female with a past medical history of asthma and hypothyroidism, evaluated by oncology after she was noted to have a left palpable breast mass on physical examination. On June 2022, she underwent a diagnostic mammogram, which confirmed a suspicious spiculated mass with prominent left axillary adenopathy. The results of the needle biopsy were the following: grade 3 invasive carcinoma, which was estrogen and progesterone receptor positive, as well as HER2 positive. The left axillary guided ultrasound and MRI biopsies were actually negative for carcinoma. In this favored an approach with surgery. So on August 2022, she underwent left lumpectomy with mapping sentinel lymph node without any complications. Unfortunately, the pathologist notified the patient that the part removed during the surgery did not contain the proved carcinoma. And when the results came back, they were actually positive for fibroadenoma. And the patient was informed of the need for additional surgery. So again, on September 2022, she underwent repeat left breast lumpectomy without complications, but this time confirming the invasive ductal carcinoma, which was HER2 positive and estrogen and progesterone receptor positive. For the HER2 positive status, she was started on paclitaxel and trastuzumab just after the surgery. And for the estrogen positive receptor, she was recommended to start treatment with tamoxifen. Of course, during all these diagnosis, management, treatment, and repeated surgery, she developed worsening anxiety. And she was followed by the primary care physician and social work, who provided some supportive psychotherapy until she was referred to us, psychiatry. So the reason for the consult was management of worsening anxiety with the plan to start tamoxifen. The chief complaint of our patient was, "I don't want to stop bupropion." So let's talk a little about the history of present illness. The patient was actually first diagnosed with anxiety when she was 17 years old. This was after her best friend unfortunately passed away secondary to cancer. At that time, she described the anxiety as fear of family members acquiring cancer or any severe medical illness. And this will keep her up awake at night. She will ruminate and she will think about this at night, members of the family acquiring these medical conditions. And throughout the day, she will have generalized worries. Now, current anxiety is slightly different. As mentioned before, exacerbated by the cancer diagnosis and treatment, but also by the recent news that the mother-in-law was diagnosed with recurrent uterine cancer. Complicated the family dynamics, which we'll talk about in a few seconds. Current anxiety is described as pure terror, accompanied by survivorship anxiety and overwhelming worries about the future. Other than the anxiety, the patient denied any anhedonia, changes in concentration, feelings of guilt, hopelessness, or helplessness. She did complain of low energy and weight loss. She lost around 20 pounds, and she attributed this to the cancer. She denied any suicidal ideation, intent, or plan, and denied any symptoms consistent with mania, hypomania, or psychosis. Now, prior to this cancer diagnosis, she was treated with escitalopram 20 milligrams for around 16 years, until she eventually developed emotional blunting. Then she was switched to venlafaxine, up-titrated up to 300 milligrams for at least 6 months with no improvement, until eventually she was started on bupropion with the stabilization of the anxiety until the cancer diagnosis. Before our appointment, she did some reading and was told about the interaction between tamoxifen and CYP2D6 inhibitors, and was nervous either of coming off bupropion or switching to another antidepressant. Let's review the past psychiatric history of the patient. As mentioned before, there is anxiety, but there was depression as well during that episode, the first episode when she was 17 years old. But other than that, no psychiatric hospitalizations, no past suicide attempts, no history of self-injury. She did psychotherapy previously in her life, which was helpful for the anxiety specifically, and right now follows with social work, as mentioned previously, doing supportive psychotherapy and some mindfulness. No history of substance use, no past or active. Regarding the medications, the one mentioned previously, and lorazepam. She's taking lorazepam as a PRN for anxiety, but mostly for imaging, such as CT and MRIs. The past psychiatric history of the family is significant for depression in the father and anxiety in the mother. The past medical history, we mentioned hypothyroidism, currently controlled with levothyroxine, asthma with no episodes since childhood, no known allergies. Family history, it is significant for endometrial cancer and prostate cancer in second-degree family members. I'm going to talk a little about the social history. So she's currently married, lives with the husband, and works as a social media manager. The family dynamics are currently complicated because of the recurrent uterine cancer of the mother-in-law, because the husband is actually the caregiver of the mother. So he's helping both, and that has made this complicated. She does have a lot of support system with her own family. Their parents actually moved from California to Boston since they found about the cancer diagnosis. The mental status examination was fairly remarkable. She was very cooperative, calm, pleasant. She reported her mood was fine. The affect was ranged from euthymic to anxious, I will say. There were no hallucinations, and the insight and judgment were fair. Now, all of this does raise a few questions. What considerations should we have when we prescribe antidepressants in patients with cancer diagnosis that are going to be treated with tamoxifen or are treated with tamoxifen? Should we switch them to another antidepressant given their CYP2D6 inhibitory effect? And are there certain SSRIs or SNRIs or other antidepressants that are safer than others? And for this, I'm going to pass it out to Dr. Greenberg for further discussion.
Thank you, Dr. Munoz Abraham, for setting out this case. Your attention to the history of present illness and to the fact that the patient had to go through surgery a second time just to make an adequate pathologic diagnosis gives us a sense of the anxiety-provoking nature of medical treatment even before she started chemotherapy. She is a 38-year-old premenopausal woman with a new breast cancer who has been receiving anti-HER2 chemotherapy and knows she will be starting tamoxifen because her tumor is not only HER2 positive, but also estrogen and progesterone receptor positive. Anxiety has been a problem for her in the past, and it is worse now. That's no surprise. After multiple antidepressant trials before cancer, she had done well with bupropion 150 milligrams each day, and she would like to hang on to that. She herself has read about tamoxifan's interaction with antidepressants like bupropion, paroxetine, and fluoxetine. Alarms have gone off. You can see that she is a planner who looks out for trouble. She is on guard and she worries in advance. Sometimes it's the pharmacy who will alert the patient to this interaction between bupropion and tamoxifen. Let's start there. How do we think about this interaction? The purpose of adjuvant tamoxifen in this setting, when there is no evidence of disease, is to prevent invisible micrometastases from multiplying. In other words, when the tumor is hormonally sensitive, when estrogen is known to fertilize the growth of cancer cells, tamoxifen acts as an anti-fertilizer. The hope is that metastatic disease will be delayed or will never happen. Oncology guidelines recommend 5 years of tamoxifen until the patient is chemically postmenopausal, when an aromatase inhibitor or tamoxifen might continue the job. Typically, patients are treated with hormones over 10 years. Tamoxifen is chosen in premenopausal women because aromatase inhibitors alone may provoke a compensatory rise in estrogen. ASCO guidelines specifically mention that prescribers of tamoxifen should have caution about using antidepressants that are CYP450 2D6 inhibitors. Take note that these two drugs, tamoxifen and bupropion, do not interact in the moment in a way that could hurt the patient early on. It is not a drug interaction in that sense. The concern is whether tamoxifen would be less effective in suppressing cancer cells over years because of concurrent use of bupropion. The drug interaction is based on the idea that 2D6 is critical to metabolism of tamoxifen. Tamoxifen has been seen as a prodrug, which is metabolized by 2D6 to endoxifen, a very anti-estrogenic compound. Endoxifen had been assumed to account for the major anti-estrogenic effect of tamoxifen. Indeed, if the patient on tamoxifen has a genotype that inhibits 2D6, if she is a poor metabolizer, then endoxifen levels are lower. However, whether 2D6 inhibition and lower endoxifen levels actually do make a clinical difference is controversial. Samples of convenience have shown mixed results. And around 2012, 2 large prospective trials did not show a difference in the breast cancer outcome of tamoxifen-treated patients by the efficiency of the 2D6 genotype. Oncologists were advised not to tailor doses of tamoxifen based on the 2D6 genotype. How could this be? Well, it turns out that metabolism of tamoxifen is more complex than was thought. Besides endoxifen, tamoxifen also breaks down into 4-hydroxytamoxifen and desmethyltamoxifen, 2 other anti-estrogenic compounds. The enzymes that break down these compounds include 2D6, but also include other CYP enzymes. Tamoxifen itself is only mildly anti-estrogenic, but there is a lot of tamoxifen in the mix, and the tumor cells may already be saturated with tamoxifen. So subtle changes in 2D6 do not seem to make a difference. In 2020, Tamura et al. Showed that a higher dose of tamoxifen, 40 milligrams instead of 20 milligrams per day, did not affect the response rate at 6 months of poor metabolizers with metastatic disease. Hayes and Ray summarized the data as of 2020 and concluded that CYP2D6 may not be important at all in the efficacy of tamoxifen. So current data suggests that we don't need to worry about bupropion-tamoxifen interaction at all. The patient wants to stay on the regimen that has worked for her, bupropion 150. Taking away a psychotropic medication that works, that the patient relies on at a vulnerable time, may have its costs. What are antidepressant options if you are cautious about whether to take 2D6 seriously or not? While paroxetine or fluoxetine strongly inhibit 2D6, venlafaxine, citalopram, and S-citalopram are only mild inhibitors. Whether you disregard 2D6 or not, these drugs remain options for psychiatric treatment. Bupropion, as you know, is a dopaminergic noradrenergic compound that has controlled this patient's anxiety. While it is not known for its anti-anxiety benefits, Papakostas showed in a meta-analysis of 10 double-blind studies of patients with major depressive disorder that patients who got bupropion did not have more anxiety than those who received SSRIs. In patients with anxious depression, SSRIs have been shown to have a slight edge for the most anxious, but no difference in patients with moderate anxiety. What should we do if this woman gets dysphoria and menopausal symptoms when she starts tamoxifen? Tamoxifen is anti-estrogen in the breast and pro-estrogen in the bones. However, it is anti-estrogen in the brain, causing menopausal symptoms like dysphoria, insomnia, and hot flashes. The challenge of coping with breast cancer is one stress, but the hormonal change adds another burden. Hot flashes are more common at night and sometimes are associated with panic-like feelings. Vasomotor symptoms and insomnia may be treated by venlafaxine 75, citalopram 20 milligrams a day, or S-citalopram 10 milligrams a day. Gabapentin 300 3 times a day, pregabalin 75 twice a day, or oxybutynin 5 milligrams twice a day also have benefit. These doses could be added to bupropion. Her anxiety had not responded to venlafaxine in the past, and her complaint about S-citalopram, which she had taken at 20 milligrams for many years, had been the numbing of feelings. A lower dose may not cause that numbing. With that, I'm going to turn this back to Dr. Munoz Abraham to give us more information about what happened with this patient.
Thank you, Dr. Greenberg. So I'm just going to provide a quick update on our case. So in the end, our patient was diagnosed with adjustment disorder with anxiety. And we had a discussion with her. We discussed these benefits and risks associated with continuing bupropion. And in the end, we decided to continue the medication because she has responded well to this with the plan to optimize the dose. We also made a referral to psychotherapy and some groups that we have in our center. And the last time we saw her, she has noted improved anxiety with this increased dose and only has reported intermittent exacerbations, usually related to imaging for her cancer. And now I do want to take this time to thank Dr. Greenberg, Dr. Fipps, and Dr. Soprano for the help during this process. And I especially want to thank Dr. Angela Landerholm, who was my mentor and guided me to this process. And with that, I'm going to pass it out to Dr. Fipps for our Q&A.
Thank you very much. Excellent presentation, both of you. And we're now going to transition over to the Q&A session. If you didn't hear at the beginning, we'll more than happy to have things said in the chat, but we're really only answering questions that are in the Q&A portion of Zoom. And we'll go ahead and start answering some of these here. First off, are there some women who may be more mood sensitive to estrogen deprivation than others? And are there any signs that could help us identify this earlier than seeing it retrospectively?
Yes, some women are definitely more mood sensitive to drops in estrogen, and others to drops in progesterone, and others to neither. The risk of depression in chemical menopause is likely higher in women with a history of hormonally sensitive moods. For instance, you can get this from the history: premenstrual dysphoric disorder, postpartum depression, or depression with natural menopause. And the risk of depression itself is higher in the perimenopausal transition.
Very good. All right. Well, thank you. One anonymous one in here is about since this drug-drug interaction is less in clinical concerns than what was previously maybe understood. The question is, would we still recommend discussing this theoretical concern with patients? Because as we saw, even within this case, and as we all know clinically, this can make patients pretty unnecessarily anxious a lot of times in these discussions. How would you recommend going about that if it still should be in the conversation?
I think putting it in the conversation is a thoughtful preparation for the fact that the pharmacy may warn the patient about an interaction. And sometimes I ask the oncologist to make sure that the oncologist is on the same page. In this case, the patient was more worried about stopping bupropion than starting it. But it's something that you could use your expertise and knowledge about the interaction and metabolism to reassure the patient with.
Yeah, I like it. Good expectation management, some therapeutic redirection from an educational standpoint even. I like it. There's another question here about, is there any role in checking endoxifen levels if you're concerned about this interaction when you're using 2D6 inhibitors and tamoxifen together?
No. It wouldn't make sense to look at endoxifen levels because we don't know their import.
Okay, very good. Do you think that in this particular case that maybe some corticosteroids may have also played a role in her anxiety during her chemotherapy as well?
Well, it occurred to me that she may have had some dexamethasone as part of her anti-HER2 treatment, because dexamethasone is used to prevent nausea and vomiting, particularly with cisplatin and carboplatin, which were not the drugs that she had. But it may have been used because to prevent hypersensitivity from paclitaxel, which is one of the drugs she was taking. And I think of steroids, corticosteroids, as a mood destabilizer that may have contributed to her anxiety during chemotherapy. Since corticosteroids are used commonly in cancer treatment, we judge hyperactivity, anxiety, agitation, and insomnia as maybe related to the dose that day of dexamethasone. And we also see people who crash to low mood when steroids are discontinued. This is a dose-related phenomenon. So for you to put it in perspective, I wanted to mention that most psychiatric side effects occur at higher doses than 40 milligrams of prednisone. And prednisone 60 milligrams equals dexamethasone 9 milligrams in potency. I tend to remember prednisone 60, that rheumatologic dose, equals dexamethasone 9. But the antiemetic dose may have been 12 milligrams of dexamethasone.
Very good. Oh, thank you for that answer. I like the equivalency piece of that. It's a good thing to keep in mind. And when you're mentioning psychiatric side effects, even from that kind of links with another question we have here about some of the side effects that the patient may be worried about from a tamoxifen perspective. How do we counsel about some of that? And are there other things that could be incorporated into the therapeutic discussion?
When oncologists talk to patients about the side effects of tamoxifen, they often mention that there can be abnormal uterine bleeding. Mostly this is from benign endometrial polyps, but endometrial cancer and uterine sarcoma can also be side effects of tamoxifen. And this was important in this patient because her mother-in-law had endometrial cancer. But it's important to note that this does not apply to premenopausal women. The risk is related to postmenopausal women, so it wouldn't apply to her. There's also an increased risk of venous thrombophlebitis, worse in the first 2 years. And so people who are at risk for clotting or more at risk for clotting will take this under advisement. And then tamoxifen may actually reduce the risk of ovarian cancer. So that's a relieving factor.
Nice. It gives a good back and forth of the risks and benefits conversation. Absolutely. Good. And oftentimes, especially in your discussion, you gave a great talk about the different types and literature that's out there about this concept. But clinically for you, if you had a patient who needed to be on an antidepressant and hadn't been on one before and was also taking tamoxifen, is there one that you particularly prefer in those situations?
I think the one that I'm surest of is venlafaxine. But I would use either escitalopram or citalopram as first run choices, because in this controversy, they were the ones most used and we have the most experience.
Makes sense. Well, thank you. Well, I appreciate all the questions that we had through there, and I appreciate your talk and the excellent case presentation as well as excellent discussion and Q&A. As a reminder to everyone, if someone missed it or you want to come back and watch this, this video will be on the ACLP website. It should be through the CL Twitter page, as well as on the Facebook page for CL PIN as well. And don't forget our upcoming webinar that will be Jennifer Knight's Glenn Fisher Research Award about social disparities in cancer. And with that, I think we're going to call it for time. I appreciate everyone coming and hope to see you again next time.